Hello. Welcome everyone to another WDx VMR. I can't believe it's already been a month since we've last been in these lukewarm seats, but I'm really excited to see everyone here. Thanks so much for joining us. Just as a reminder, WDx VMR is a space where very near and dear to our hearts. It's a special place where we sort of try to elevate women in medicine while we learn together and discuss a clinical unknown together. We're really excited to be here today. We'll start off with some discussions and then just a few reflections and then get started. I can start with an introduction. My name is Smitha. I'm a second year resident at UCSF, though I guess as of this week, I'm going to be a third year resident, which is really crazy. When I'm not in the hospital, I really like running and hiking outdoors with my good friend, Anna Fratz. So I will turn it over to Anna to introduce herself and to tell us a little bit about the reflection for today.
Hey everyone, thank you, Smitha, for welcoming everyone into this space. Super nice to see you all and meet some of you. My name's Anna. I, like Smitha, am in this second to third year transition as an internal medicine resident in San Francisco, and very excited for today. I agree with you, Smitha. It really doesn't feel like it's been a whole month since the last case, but here we are. We're really excited to do this case with you all today. Something I like doing outside is like being outside with my dog, hiking, or I haven't been able to successfully bike with him. I have like a bike trailer that I'm trying to get him to be able to sit still in the back of, and he jumps out every time. So if anybody has any tips, I would welcome it. Anyway, that's what I like to do outside of medicine. The reflection that I asked for folks to kind of think about today, and that we'll hear some responses on, is something that you're proud of in 2021. And the reason I specifically thought of that reflection is because I often find, like, in the kind of general professional environment, it perhaps doesn't come as like we're not as like conditioned as women in the professional environment to kind of talk about our accomplishments and kind of talk about like all the things that we're doing really great, which is everything all the time. And it's a really important professional development skill to learn how to become more comfortable talking about the things that you're doing so well. So I thought that if we can talk about just one thing that we're proud of all of the amazing things that we do, it's one, a great form of self-love and recognition of all the great things we do. And then two, it's a really good professional development skill to just be like, this is something that I did great, and get more comfortable with saying the things that we do really, really well. And so I can start us off with a reflection. So something that I'm proud of that I've done in 2021 is I was having a great interaction with a patient, meeting them for the first time. And at the end of the interaction, the patient referred to me as their physical therapist. And I was like, oh, I'm actually your doctor. I'm taking care of you. And I like introduced myself as their doctor like multiple times throughout the interaction, wearing a big badge that says doctor. And I corrected myself. And I'm the type of person where I don't think I'm like easy to like walk all over, but like I tend to just be like more polite and just kind of like let it slide. And while it's not something that like deeply irks me, what I thought about in that moment is that like for every one of the me's in that situation, there could be someone who's, having a different day, in a different mood, where that type of interaction with a patient just hits all the wrong way and really can like derail a week, derail even like someone's whole sense of identity in the workplace, and especially in a field like medicine. So I felt proud of doing something that I don't normally do in that circumstance. Anyway, I'm gonna pass the torch back to Smitha actually for her reflection, and then we'll go around to the rest of our discussants and our case presenter. Cool. Thanks again, everyone, for being here.
Awesome. Thanks so much, Anna. And just hearing you share that reflection, I was like, oh, thank you. Every moment that we take to sort of like reinforce that we all deserve to be recognized in our roles is really wonderful. I would say one reflection I've had recently is one of my goals for this year was to do more like structured teaching. I often get in my own head about like, well, do I have anything to teach? Like, everybody already knows everything. And it's actually been really fun to solidify my own learning and like present it in a more structured, like 5 minute bite-sized teaching. And it's like spurred a lot of questions and thinking for me. So I've had a lot of fun doing that on Words this past month. I will pass the mic over to Annette to introduce herself and tell us something that you're proud of this year.
Hey everyone, I'm Annette. Currently zooming in from Boston. I'm I guess, fourth year now at HMS. Something that I'm proud of, not really related, I guess sort of related to school, is just carving out more time to do non-school things and things that I love doing outside of school. I think we do our core clerkship year second year, so third year on sub-Is, it's been nice to not have any shelves and just come home and do whatever it is that I like doing, and making time for that has been hard, but also I've worked on it and it's been good.
Great. Maybe we can popcorn over to Zoya.
Hey everyone, my name is Zoya. I'm calling from San Diego today. I'm actually starting internal medicine residency at UC San Diego tomorrow. So really excited about that. And in terms of things I like to do for fun, I also really love to run. I bake a lot. I have an egg allergy, so for me, like vegan baking and baking without eggs is like kind of a passion of mine. And then in terms of things that I'm proud of, I think in 2021, the biggest thing was that I graduated from med school at UCSF and matched into internal medicine residency at UC San Diego. And I think that, for me, I actually took 5 years to complete medical school. I took a research year because I was, not really sure what I was applying into. During third year, I loved so many things. I'm glad that I took the time to try to figure out what I was really passionate about and interested in. And so I felt like once I graduated and matched, it really felt like, I felt proud of myself for taking the time to figure out what I wanted to do. And so, yeah, that's, that's it.
Great. Maybe we can popcorn over to Aisha. I don't think we're having trouble hearing you, Aisha. Was that just me? Okay. Maybe in the meantime.
Can you hear me now?
Yes.
You can hear me now?
Yes.
Okay. So it's really nice to meet you all, and I'm plugging in from Pakistan actually. As of next month I'll be a final year internal medicine resident, and I have a small family, so outside of medicine, that's what I do. As for something that I'm proud of, yeah, so it's probably more of a personal development, but I starting this year, I realized that if I want to do something in life, I have to start believing in myself. And I have to start because there was something in my mind that, if I talk about my plans, I will just ruin them. I will jinx them. But now I talk about them all the time, and I'm like, the more I talk about it, I think the more the chances that I might be able to do what I want. So yeah, I think I'm proud of that, and no, my plans weren't jinxed, so that's a good thing. So yeah, just a small personal development goal that I managed to do this year. This, apart from all the COVID and surviving COVID and going through all that.
That was so awesome. Thank you so much for sharing that, Aisha. And we're so happy that you're tuning in. I think I can imagine it is maybe at a inopportune hour. But we have an incredible group of women today, and we're going to have a lot of fun, and we're all going to learn in discussing this case together. So maybe what we can do is we can turn it over to Maria. We have Maria and Valeria in the background who are crafting, doing our beautiful scribing and teaching points. Thank you both. And we can get started on the case. And just as a reminder, Aisha, to talk nice and slowly so that we make sure we capture all of this rich information. Cool.
And Zoya and I will take the first aliquot, and Anna and Annette, y'all will be on the second.
Right. So can you hear me, guys? Okay. So it's 5 aliquots, starting with the first one. We have a 30-year-old male who presents to the ED of a neighboring hospital with seizures, altered mentation, and irritability. He was all right a couple of weeks back when he had a headache, followed by an episode of generalized tonic-clonic seizure witnessed by the brother. He remained drowsy for 10 minutes after the episode, but regained consciousness thereafter. The seizures recurred with increasing frequency over the next few days. Interictal periods were marked by profound irritability and behavioral disturbances, after which he was taken to the hospital by his brother. By the time he arrived, he was diagnosed to be in status epilepticus, intubated for airway protection, and shifted to the medical ICU of that hospital.
Sorry, I muted myself. Wow, this is such an incredible start to a case, and really, a sad story. And we're really worried about this patient. Zoya, when you hear about this history of the seizures and the altered mental status, what's coming to mind for you?
Yeah, so I guess the first thing I'm thinking about is in my mind, my differentials for seizures, altered mental status, and irritability are kind of different. And so for me, I think I'm feeling like a little bit overwhelmed that they're all kind of presenting together. So I'm trying to think about, some of the overlapping things that can cause these things. When I hear like seizures and altered mental status and irritability, I think I'm kind of gravitating towards like a primary CNS pathology. Given this person's age, I'm kind of thinking something potentially infectious, or a primary seizure disorder, or like such as epilepsy, or even a intracranial malignancy. I think some things that I'd want to know about are if, he had any recent like head trauma. I would think about, potential consequences of that. If he is having any of those, since he had a headache, if he was having any like red flag symptoms at the time of that headache, such as like fevers, or if it was worse in the mornings or positional, it would kind of lead me more towards maybe some sort of, intracranial malignancy. And then I'd want to also know like travel history and exposures. I think that CNS infections such as like meningitis is something that I'd be worried about. Although it seems like his presentation is a little bit more, on the subacute range and not the acute range. So I think I'm leaning a little bit away from that. And then I think it would be prudent to go through the altered mental status schema of MISTO, so anything metabolic or infectious, structural, or toxin related. So see if he has had any ingestions recently, or if he started a new medication recently. So I think I have more questions than answers, but I think those are like kind of the things that I'm thinking about and want to gear my history and physical exam towards to kind of parse out exactly what's causing his seizures.
So yeah, that was fantastic. I think like such a rich diagnostic approach to, someone who's very sick, but just to step back and say, what are we missing here? And diagnostically, I really, I'm simple-minded. I can't keep that many mnemonics straight in my head. And I love the MISDO mnemonic for altered mental status broadly. And I think actually, just like you mentioned, it overlays really nicely with thinking about a diagnostic approach to seizures in general. So thinking about just to fill in your schema. So thinking about what metabolic things can lead to seizures, thinking about electrolyte abnormalities, glucose abnormalities that can lead to seizures, things like hyponatremia can often present with seizures as well. So many metabolic derangements can present this way. Infectious causes, you brought up, could this be sort of an intracranial or CNS type infection? And the differential for a CNS infection is very broad, but in the acute setting, our priority is to rule out an acute bacterial and often acute viral meningitis. And those are the things that kill people the fastest. And the bacterial causes are very broad. The viral one that often comes to mind is HSV1, which involves the temporal lobes and can often present with seizures. And then structural lesions, you brought up a malignancy and a bleed. So a history of trauma, is there some sort of blood in the brain, which can be an irritant and a nidus for seizure activity, or is there something structural like a tumor that can lead to seizures? And then toxins, thinking about, are there meds on board that could lead to this, or are there toxic ingestions or the withdrawal of a toxic ingestion? So alcohol withdrawal is one of the most common precipitants of seizures that we see in the acute setting. And then stepping back and thinking about who is our host. So we have a 30-year-old male. Why is this 30-year-old now presenting with such severe seizures? Is there something about something that was either going on in the background, or is this potentially an immunocompromised host? So making sure that we're checking for HIV and thinking about what his immune status is. And then just given how, fulminant this presentation is, thinking about other exposures. So travel history will be one thing. Has he been hiking in the woods and that sort of thing, to think about, like, how do we prioritize and broaden our differential appropriately. So I would be sending off a really broad workup. And then whenever we see sort of someone that's in status, I think in order to protect the brain, we need to be thinking about management of these seizures alongside sort of thinking diagnostically. So we talked about this diagnostic approach, but we want to make sure that we're getting this status under control. So making sure that he's getting appropriate dosing of Ativan and getting other AEDs on board as well to try to get control of these seizures. And so things like Keppra, phosphonatoin, et cetera, can be really helpful to try to see if we can get these seizures under control and protect his brain. Great. Back to you, Aisha.
Right, so that was so amazing, guys. So a little bit about the patient, just to answer a few questions in the previous discussion. So there is no history of trauma, and the history of fever is actually plus minus. The brother didn't give a history of a fever prior to the events, and after the events or during the events, I'm unsure if he referred to the fever as a consequence of the seizures, or was it really a fever. So I wasn't sure about that. So our patient is a laborer by profession, and he works mostly with cement. He has no relevant past medical or surgical history. He takes no prescription meds. He has a 5-pack-year history of smoking. He also takes cannabis occasionally and chews tobacco at times too. And he's married with 5 children. He has no allergies, and family history is insignificant. Yeah, so that's about it for the second aliquot.
All right. Really, really interesting. That was such an incredibly rich discussion. Zoya and Smitha, thank you for starting us off strong. All right, Annette, we found out a little bit of maybe some pertinent negatives. Whether, I guess, feel free to comment on any additional thoughts you have from the first aliquot, and then also maybe how some of these pertinent negatives might kind of filter your thinking for this gentleman with new onset seizures.
Yeah, sure. That was awesome. I think one thing I'm still wondering about is whether the seizures, altered mental status, and irritability are due to one thing or two things, or are they separate? I think most likely they're related, but still good to keep in mind it could be two different etiologies. I think what's interesting to me is this is someone who's relatively young and has no past medical history, is on no medications, doesn't seem to have like an alcohol use disorder. So I think that sort of makes like toxin or like any toxic ingestions a little less likely. We don't really have any history of like travel. I don't know, but I think one thing that we were thinking about was whether this was sort of some infection that had spread to the CNS, and if he hasn't traveled anywhere, that makes it a little less likely, or if he hasn't, had any behaviors that might increase risk. I think all of the other things that Smitha and Zoya talked about are definitely still on the list, that I would still think about. Yeah.
Yeah, I agree with you. I think, there's maybe like limited things that are ruled out from a totally negative past medical history, but I think you hit the nail on the head in that like we still should be thinking about this so incredibly broadly. And I love that you have, before clumping, you're separating still, because it's like a first onset seizure in a young person. And I think the differential is so incredibly broad. And then unfortunately, probably we're not going to be able to collect a ton of past medical history from him. And I find, at least in my my experiences, that like young men like don't love coming into like medical care and like tend to minimize and underreport a lot of symptoms as well. And so it might kind of, if there is some type of systemic process going on, I think it'll be really kind of important in our evaluation that we consider that we're not able to collect like a huge robust history from him. But I thought, I don't really have anything to add on top of what you already said. I love the idea of being really broad. I can just share like a few things that I've learned as part of like the workup of kind of first onset seizure in young people. And typically like in young people, and I don't actually know like what the age point cutoff is, but like there's some age point cutoff where we're just like, is this the first manifestation of epilepsy? In older people, certainly like stroke is the first thing that you think of for first onset seizure for people. And then as people, when they're younger and younger, I think infection as a trigger for epilepsy versus just infection more broadly, typically of like the CNS, would be the most common cause. But I don't know what the age cutoff is. And I just wanted to piggyback on something Zoya had said, certainly like thinking about localizing this to the intracranial space. One additional like nice framework that we can have for like altered mental status and seizure is like thinking about, is this an intracranial versus extracranial problem? And I love the idea of like layering on their altered mentation, their irritability, and these progressive headaches that they've had is really something that might localize us to the intracranial space. And certainly getting head imaging for this young man will be important. Some things that I've learned as part of like kind of first steps and workup of first onset seizure for folks is that everyone gets a head image, like a detailed head image with an MRI. And if you have somebody who's had seizures and maybe they're happening with like increased frequency, thinking about the safety of the patient and being able to undergo the MRI. In this case, we're fortunate and the patient's already been intubated, so they're protecting their airway. I think they've been intubated. We did learn that, right? Yes. Okay. And so they're protecting their airway, so it'll be safe for them to go into the MRI scanner. And then in terms of thinking about EEG and LP as kind of two other pieces of kind of like the diagnostic armamentarium of neurologists, EEG is indicated for patients that are in status, which, can include like kind of seizures that go on for a long period of time, or if you're having recurrent seizures without interictal return to normal. And then additionally, patients that have something that might localize from an infectious standpoint to the CNS, doing an LP for them. So say this patient had to come in reporting fevers, or we see on their labs that it might look like they're infected. They might undergo an LP, of course, with head imaging to guide whether or not that would be a safe thing. And that's really it in terms of like the diagnostic steps. Of course, we're going to send like broad labs, thinking about metabolic causes and all the great things that that Zoya and Smitha talked about. The only additional thing that I started to wonder with the occupational exposure is like if there could be some type of like weird elemental exposure that this patient has. I know that oftentimes, I guess I shouldn't say oftentimes, but like something that I think about when we like see weird CPS cases and there's like some type of like neurologic signature, thinking about like kind of strange elements. And oftentimes for patients, it can be in the form of like makeup products or like skincare products, because you can get transdermal absorption. I don't know if that's the case for like cement. I can imagine there's like a ton of elemental exposure, but I don't know any that like specifically cause seizures. But that would just be something that would maybe be on my radar if like kind of the initial workup doesn't come back positive. And then in terms of treatment, the one thing I learned from my ED rotation is that apparently there was like some recent trial where the first like anti-epileptic agent you use, there was like a recent paper that showed like there was no difference between valproate and Keppra and then Phenny or Phospheny. So it's like kind of whatever your pharmacist choice is, just give it, which I think helps us feel all a little bit better when we're super stressed managing a patient in status. And those are all of my thoughts, and I'm really excited to learn more. Zoya and Smitha, any other thoughts? Otherwise, maybe we can turn it back to Aisha. All right.
Oh, sorry.
Oh, sorry, Zoya, go ahead.
No, go for it.
So I think the only thing that I was thinking about is I couldn't remember, but does he have like a few kids as well, or like children in the home? So I think the only thing that like kind of caught my attention was that they're also like a source of infection potentially, and so I think that kind of like led me to move that a tiny bit higher on my differential.
That was awesome, Zoya. All right, Aisha, we'll turn it back to you. I'm actually scrolling through the list. Does anybody see? I wonder if Aisha's internet cut out.
I don't see Aisha.
Oh no. Okay.
We're hanging in suspense.
Yes, we are. I'm seeing some great, and if you guys see her join, feel free to let her in. I'm just going to send her a message on WhatsApp. I'm seeing some great kind of infectious differentials in the chat that I'm loving.
I'm like now scrolling through, and just neurocysticercosis was not on my radar, so thank you. The other sort of management pearl about just like when someone is in status is like often a BBG can get you some quick electrolytes. And if there is any concern for like a hyponatremic seizure, giving 3% hypertonic, 100 cc's of 3% hypertonic saline right away is like what we should do right away. And I feel like oftentimes I certainly get nervous about doing that. And you can actually give 100 cc's up to 3 times for correction of the hyponatremia and management of the seizure. And it should pop them out of it. And then the only other like management pearl that I learned relatively recently in the ED was actually that while many of the AEDs are equivalent, phosphenotoin is not helpful for alcohol withdrawal. You want to make sure that we're sticking to the benzos, the propofol, the barbiturates for alcohol withdrawal related seizures, and to watch out for that phosphenotoin can cause complete heart block, which happened to someone that I gave it to. Awesome, thanks Kushal. And also, yeah, giving some bicarb can also be helpful and potentially a little less scary to give.
Aisha has just told me, she said 3 minutes, she'll be back. Something happened with her internet. And so she's troubleshooting. I am wondering, and I'm looking at you, AMK / anybody else in the chat, if for whatever reason Aisha's internet doesn't come back, if anybody has a short case that we could transition to. And I also wish that, or maybe also AMK, if you wouldn't mind texting Jack, I actually think he has a copy of this case that maybe somebody else could present. And I see Promise, who could maybe finish presenting it for us, who had contacted me and was eager to present. Some on the fly troubleshooting. Wouldn't be a virtual morning report without it.
A little bit of gotta keep it interesting.
Yes, exactly.
Any other thoughts?
Question, if you like asking, but I was just wondering, you know, with new onset seizures, of course, I always think about like provoked seizures, and I actually recently learned that provoked just means, you know, something causing it that's acute and reversible. And in this patient, and you know, like provoked, we're thinking like metabolic hyponatremia, hypoglycemia, very quick fixes. But in this patient that has had like a couple weeks of seizures, you know, I really put like very low in my differential like metabolic causes, just because I don't think somebody could like stand so much time with like a metabolic provoked cause, and definitely not being like episodic. I would just assume like the illness script for like provoked metabolic seizures would be like having a seizure and like deteriorating really fast. But I don't know if like you can give me some input on that. Like, is that like wrong to assume something like that, or should like I be more cautious about it?
It's true that I think like this seems less likely, right? Multiple seizures, like, and it's probably not acute hyponatremia, but it's not improbable, I think, to have like multiple things going on at once. And like maybe if you have multiple triggers under like an already like like a brain that's already revved up to seize, and you have a metabolic abnormality on top of that, perhaps that triggers you to go into status in a way that maybe it's not the primary driver. But I think like any time we see a seizure though, like walking through that, making sure that we like check those things is really important, because you can have multiple things going on. And particularly if he's been seizing, he's had headaches, he's not drinking, maybe his sodium's dropping, like yeah, it's less elegant, but possible, I think.
I really love that that explanation, Smitha. And then the idea too of like using this time course, Maria, I think is so great. So as we're talking about super morbid things like bacterial meningitis, certainly it's probably not something where untreated bacterial meningitis is, like, in my mind, having seen it one time, like it's a fatal diagnosis. You don't live with that. And so I think using the time course too, I can tell that you have your neuro VMR hat on and using the localization and time course to help us. So AMK, or actually, I have a copy of the case now, I believe, according to Aisha. Has she been able to successfully rejoin that you all have seen?
I don't see her.
Jack just emailed me some of the details, but it's not like the full case. It's just kind of a summary of the aliquot.
Okay, all right.
If you have the case, you want to forward it to AMK?
Yeah, I can go ahead and do that. And I could even send it to Promise, because I know Promise was also eager. Promise, do you want to send me a private message with what your email is? And then, although I think you've already sent it to me, but it would just be helpful. And I can send it to you and maybe you can finish.
That would be awesome.
Thanks you all for sticking with us as we troubleshoot.
Any other thoughts from
I
the chat?
don't think I can send a. Oh, sorry.
Well, while we're waiting for that, do you want me to just like present like one of the
Sure, that sounds good. Zoya and Smith are up.
So since patients
clinical course
at their hospital, there weren't exact findings, but the GCS was low, blah, blah, blah. Baseline stations were essentially normal. CSF shows lymphocytic pleocytosis with normal protein and glucose. Baseline non-contrasted CT of the brain is normal. He is managed for viral encephalitis. HSV PCR was not sent. However, his level of consciousness did not improve, and the tracheostomy was done on day 10 of ventilation. Remained obtunded with a GCS of 6 of 15 and is referred to this hospital at the moment.
Anne-Marie, I had a little bit of trouble hearing you. So just to, I think Maria captured what I heard. The LP showed a pleocytosis with normal glucose and protein, a normal CT brain. Was that non-con? Okay. Oh, I'm having trouble hearing you.
I can present, but I just couldn't private message Anna my email, but I sent it to you on Twitter.
Okay, promise. I have your email. I'm going to send you the case as we read this portion. Thank you, Anne-Marie. And then promise we'll let you round us out for the rest of the case. Thank you so much.
Anna, should we chat about the data that we have here? Okay,
I think
perfect.
so. Yeah.
Awesome. Zoya, what, I think it's always hard with that first aliquot that dumps all this data on us. When you are looking at this LP data, the CT data, what is sort of moving up or down on your differential?
Yeah, so it's been a while since I've looked at LP data, but when I see lymphocytic pleocytosis, I think that's like an increase in the like white cell count or lymphocyte count, if I remember correctly, and please correct me if I'm wrong. But I think this kind of leads me towards something inflammatory in the CNS. I think is like the big picture thing that I'm thinking about. And again, if I remember correctly, the glucose is altered in something like bacterial meningitis. So that kind of moves lower on my list, in addition to what we had talked about earlier in terms of the time course, it not really quite fitting with bacterial meningitis. So when I see like pleocytosis, I am kind of thinking, yeah, like inflammatory, whether it's you know, infectious, like a viral infection, or I don't know, maybe even something autoimmune, just something that's causing inflammation in the CNS. And with the CT being normal, I think that lowers my suspicion for like an acute bleed. However, if we're thinking that this was attributed to some sort of trauma, and it seems like the time course was like subacute, I think it's totally possible that like if he, and I guess it's not even in the history, but just like thinking about it like academically, like I think if he had old blood, I'm not sure how well that would even show up in the CT. But I think like trauma or an acute brain bleed at least is moving lower on my differential as well. And honestly, I think that's kind of all I have for this aliquot. I apologize, but happy to hear your thoughts.
No, You said like all this amazing rich information, then said that's all I have, and you really, I think, hit the nail on the head, which is we have this lymphocytic pleocytosis, which is pathognomonic for inflammation within the CNS, because the blood-brain barrier should keep that space incredibly sterile, and so or without having a lot of white cells. So the fact that we are seeing that suggests that there is inflammation. So I think you very much hit the nail on the head. And maybe I'll just talk about sort of my DDX for thinking about lymphocytic pleocytosis, and then layer on kind of the time course and this patient's presentation that we have. So when I see lymphocytic pleocytosis, my first branch point is this infection or is this not infection? So I'll talk about the non-infectious bucket first. Rheumatologic things like lupus, sarcoid can often lead to a lymphocytic pleocytosis. Sometimes, if you have sarcoid in the brain, you'll often see lesions, maybe not with a non-con head CT. And so thinking about what is the sensitivity of the image that we got, and do we need advanced imaging like an MRI brain is something that sort of comes to mind. And then thinking about other things like a carcinomatosis meningitis. So people with cancer in the brain or leptomeningeal disease can have a lymphocytic pleocytosis just from the cancer itself. And you actually need an MRI brain to look at whether the meninges light up. And then when I think about the infectious bucket, all of the types of infections are at play. So bacterial things, viral things, fungal things, and parasitic things. So certain things like bacterial meningitis, actually 10% of them, despite us normally thinking about them as presenting with a predominantly neutrophilic lymphocytosis, some 10% of them, regardless, still present with a lymphocytic pleocytosis. Often, if that bacterial meningitis has been partially treated or has been present for a longer period of time, a TAP that happens later in that patient's course will often show lymphocytic pleocytosis. But just like we said, it would be atypical for a patient to have bacterial meningitis for a few weeks. Other atypical infections like listeria, TB, syphilis, Lyme disease can often present with a lymphocytic pleocytosis. And then I think about viral causes. So the enteroviruses, the herpes viruses, acute HIV, and West Nile are some of the viruses that come to mind for me when I think about a lymphocytic pleocytosis. And then certainly fungal etiology. So thinking about cryptococcal meningitis, and then other endemic fungi, sometimes here in the United States, like coccidioidomycosis, can cause lymphocytic pleocytosis. Someone in the chat, I think, had brought up toxo. So Toxoplasma gondii as a parasite can lead to lymphocytic pleocytosis as well. But when I think about like the top 3 things that I think of when I see lymphocytic pleocytosis, I think about a partially treated bacterial meningitis, a fungal meningitis, TB, and malignancy. So a very long list of things, but those are sort of like the top things that I run through. But the spotlight just essentially broadens, and our job is to really interrogate all of those things, because while I didn't hear what sort of empiric antimicrobials the patient got, many of these atypical things he will have not received treatment for. So important to make sure that we're ruling it out. I'll pause there. Zoya, any other thoughts? Anna, Annette, any other thoughts?
I'm just sitting back and enjoying the discussion. That was so amazing. So it's one thing that I'll be interested in is seeing what his PCR is sent. I have learned that a PCR is still valuable for the viral meningoencephalitides, even after they've been on treatment for some time. And so it'll be interesting to kind of see what those studies show.
Totally. And the last thing I will say is here at UCSF, and I think this is going to be more commercially available, we have what's called metagenomic sequencing on the CSF. And the idea behind that is, like I mentioned, the CSF should be a sterile space. And so we essentially can just amplify any nucleic acid that we see in the CSF, and we can segregate them between human and non-human. And we should essentially have no non-human DNA or RNA in the CSF space. And so if you see that, you can amplify it and sort of match it against a PCR database that we have to sort of see if you can find any matches. And that has actually helped in our hospital diagnose many of these cases, similar cases of patients who have been sort of diagnostic mysteries, in part because a lot of the tests that we send for these organisms have sort of confidence intervals and sensitivities and specificities, and you can have falsely negative tests. So the metagenomic sequencing, I think, will become more viable and available soon.
All right, Promise, can we turn it over to you to walk us through aliquot 4?
Yeah, sure. Apologize in advance if I haven't learned a term yet and don't know or pronounce something wrong. So let's see. On arrival to the hospital, the patient's oxygen saturation is at 2 liters per minute, and then systemic examination is unremarkable. For neuro exam, his conscious level corresponds to a GCS of 6 out of 15. Eye opening is spontaneous, but there are no tracking or meaningful movements. He tries to resist opening of his eyes, but there is no response to deep, painful stimuli, such as the sternal rub. And then brainstem reflexes include pupillary light reflexes, corneal reflexes, and cough and gag reflexes are all present. Plantars are down. He has intermittent twitching movements involving facial muscles with gaze deviation to the left. And then a repeat CT brain and MRI brain are normal. EEG shows diffuse encephalopathy, but no evidence of subclinical status or seizures. And a repeat CSF again shows lymphocytic pyocytosis, but the total cells are 20 now. And there are no red blood cells, and the protein and glucose are normal. HSV PCR sent subsequently turn up negative.
An interesting turn of events. I will also just like to shout out that I think cases where it kind of just walked us through a patient's clinical course with kind of data informally woven in between, there are remarkable cases, really great learning. So even though, you know, sometimes I feel like I have cases like this and I'm like, I don't want to present them, like they're not in like perfect morning report format. They don't need to be. Like learning from this clinical course is very real life and really rich learning experience for us all. All righty. Please help me out with this, Annette. This is a kind of interesting turn of events with the patient's clinical course, and wondering how you're digesting it all.
I might just word vomit a little bit here. I think I'm a little confused. So sounds like some sort of probably infectious and lymphocytic pleocytosis was treated for a viral encephalitis, and then patient somehow his lymphocytic pleocytosis got better, but clinically isn't doing better, or is still GCS level is low and still has an oxygen requirement. I think things that stick out to me are I think I heard there was a gaze deviation of some sort, which makes me feel like, is there any changes that are now sort of less reversible than before? Other things I'm thinking about, yeah, somehow he still has an encephalopathy and we're not quite treating the right thing, given that I'm not sure what else was tested other than the HSV PCR. Honestly, I'm not quite sure.
Yeah, I'm not sure either. And I feel like I struggle most in cases like this, where you've pointed out the exact discordant piece is that clinically this patient they're not getting better despite some of their numbers getting better. And then I'm like, okay, what do I trust? And I often I'm just like, punt it to somebody with more experience. Tell me what track I should be following right now. But I think realistically, like we're going to be doing both things. I think we can like keep both in mind, but ultimately like the patient's clinical status is really going to like guard or like kind of guide kind of their overall trajectory, and like, are they going to get better or worse? And sometimes we can get a little bit bogged down in numbers, but a patient's GCSF failing to improve. Whoa, GCSF, that was not the word I was looking for. Glasgow Coma Scale. I told you, promise, I would say wrong things tonight. That will ultimately, I think, guide more like how I'm thinking about the patient. And so I'm concerned that they haven't really had a response to treatment. And I don't know, I feel like I learned that you can get irreversible mental status changes from HSV encephalitis or meningoencephalitis that had like delayed onset of treatment, but it doesn't sound like we're getting a signal from the LP, a signal from the imaging that there's like kind of the classic HSV signs. And so, it'll be interesting to see, we didn't hear, like Smitha had mentioned, if they were treated with like any type of other antimicrobial aside from just antiviral treatment for HSV encephalitis or viral encephalitis. We presume they were thinking about HSV. And so I think that would be something that I'd still be interested to see, like what were the cultures and kind of what additional things were sent. I really don't have much to add, Smitha. That DDX for lymphocytic pleocytosis was so exceptional, but I'm like starting to think that we're probably in the non-infectious bucket now. Like I'd be thinking about this similarly to like the patient that I'm seeing in a clinic and they come in and they have something on their chest x-ray and I think that they have a pneumonia and I'm giving them antibiotics and they come back to me 2 weeks later and they're like, I'm still coughing, I still have fevers. And then I'm like, I might have missed the diagnosis. And so I think that's how I'm framing the case at this point, and that I'm much less worried about a viral meningoencephalitis for them. And I'm more worried maybe about there being an underlying autoimmune cause or a malignant cause even, and would be interested on like some of the more advanced fancy studies that I don't know the names. It's like Joe and like other like weird 2-letter abbreviations, things that I don't know for like autoimmune encephalitides and stuff like that. I agree with you. The patient's gaze deviation is interesting. And the one etiology that came to mind, although I don't think can really cause such a profound encephalopathy, is cerebral like venous thrombosis, and with like with the cerebral sinuses, like I think that you have like an abducens nerve that like runs through one of them and can cause at least like a lateral gaze palsy on one side. Maybe this is bilateral, but is an etiology both of seizures and like could explain headaches. But like the encephalopathy is really like the profound finding at this point. And I think I'm like framing this patient as like a young man who presents with progressive seizures, hasn't responded to empiric viral meningoencephalitis treatment, who continues to have a lymphocytic pleocytosis and profoundly altered mentation. And so I'm thinking probably mostly about not infectious, autoimmune or malignant causes at this point. And would be using neurologists to help me think in a smarter way about this. But I know who to call, and I use people to help me learn more about things I don't know very much about. Those are kind of my thoughts on this. So I think my bottom lines, I don't think this patient necessarily needs to be on antibiotics. Presume that they've like completed treatment course for bacterial meningitis as well. Probably okay to take off viral causes of viral, and then using our consultants to help us think more carefully about what type of additional diagnostic information, probably from the CSF, I think would be the most helpful. Annette, Zoya, Smitha, any additional thoughts before we hear the rest from Promise?
One thought I was thinking about is like, okay, so if we do think, we are sort of in this bucket of maybe atypical infection versus autoimmune, and what kinds of autoimmune diseases present with an autoimmune encephalitis, the ones that come to mind for me are NMDA, MS, and sarcoid. And I guess lupus and like other vasculitides can sometimes do that. Are there other ones that come to mind for you all?
I do think I have heard of Sjogren's having an encephalitis associated with it, but I don't know much about it. And I think
Yeah.
it's not common.
Yeah.
Actually, if you don't mind, had a quick question. How common is it for this to be like the first presentation of an autoimmune, or are there things that, you know, maybe he had that we missed or he just didn't present so we don't know about?
In my mind, this is not a bad illness script for autoimmune encephalitis. It's the right age demographic. Typically, we tend to see more young women than we do young men, but it's the right age. Mental status changes, particularly with like irritability, sometimes psychosis, are quite common. I don't know how common seizure is, but I can imagine, I mean, it's an encephalitis. I can imagine it being fairly common. But it really is not like my illness script and the limited experience I have managing autoimmune encephalitis is not far off from how this young man is presenting. I don't know, Zoya Smith, or if you all have seen a little bit more and can talk more about that.
No, that's my sense as well.
Zoya, any additional thoughts before we turn it back over to Promise?
No, I think I'm good. This was an awesome discussion.
Okay.
All right, Promise.
So
I'm so sorry. So the CSF for autoimmune encephalitis antibodies and anti-NMDAR antibodies came back to be positive. So I think you guys really did a really great job of guessing it.
Amazing. Thank you so much, Promise. We really appreciate you stepping in to present the case to us. And that was a fantastic discussion. You all, I really appreciated discussing with you all. I learned a lot. Promise, were there any teaching points that Aisha had kind of looped into this? I feel like a lot of our presenters often do, but if not, that's totally fine. And we can turn it over to Valeria to round us out.
Yeah, I can read the 2 learning points that are in this case. So the first one was that anti-NMDAR encephalitis is the most common form of autoimmune encephalitis, and it should be suspected in young patients who present with neurobehavioral symptoms and signs. It's characterized by the presence of antibodies to GLU-N1 subunit of the NDMA receptor. And the antibodies are pathogenic and cause cross-linking and subsequent internalization of NMDA receptor, which is why a lot of the anti-NMDAR encephalitis closely resemble those of dissociative state that you see, like we see in NMDA antagonists like ketamine. And then the second teaching point is that early diagnosis is key. So up to 60% of the patients may have an underlying neoplasm, usually a teratoma. And treatment outcomes depend on the institution of early management strategies, which involve immunomodulatory and removal of the tumor where applicable.
Awesome. That was so high yield. Thank you so much for sharing that, Promise. And I also am really eager to hear from Valeria. Maybe before we get there, I'm curious, Zoya and Annette Smith, any reflections on the case?
I can go ahead. I am like very humbled by this diagnosis. I think, we started off really broad and our differential was so large, which I think made for such an interesting discussion. And I learned so much. And yeah, I think it's something that this diagnosis is something that I actually don't really know a whole lot about. So I'm like super humbled by this whole case. And I thought it was really cool how we started off really broad, but then with each aliquot, we got more information. I felt like each discussion was so rich in terms of how we narrowed it down and how we, changed our thinking about the patient. And so, yeah, I really appreciated being here and I learned a ton.
Just want to echo what Zoya said. I also loved Smith's lymphocytic pleocytosis differential. It's something I haven't thought about in I don't even know how long. And I loved how it was split into like the infectious and the non-infectious bucket. Yeah, it was awesome.
I will just say I'm blown away every time I do one of these cases. I learned so much from you all and was really humbled both by this case and by you all's discussion. So thank you for letting me learn from you. And then I'm like scrolling through the chat and seeing that Kushal called it from Alcott 1. And so really I get become tachycardic whenever there's like a neuro case. And so just really grateful for this entire community for helping us learn together.
I echo everything that was said. That was so much fun. That was so awesome. And I can't wait to learn more about NMDA receptor encephalitis sometime in the next couple days. I like to use these cases when I'm just like, I haven't thought much about this case. It's like there's now a case that I haven't seen clinically that I can haven't been the primary person taking care of them to use this as a learning opportunity to really solidify something to attach the learning to. It's much more meaningful, I find. All right, without further delay, let's turn it over to Valeria to go through these beautiful teaching points. Thank you so much for putting these together. And thank you, Maria, for your awesome scribing. We really appreciate you.
Yeah, this was really an amazing case. Thank you so much to Aisha and to Promise for presenting. Always great to hear some neuro VMR. And so we started the case with altered mental status and a really good mnemonic. Remember, the etiologies of AMS is the mixed mnemonic, in which you consider metabolic causes such as glucose and, for example, thiamine encephalitis that could be due to some alcohol consumption, as well as infection, structural causes and toxins such as new medications, withdrawal from some medications such as opiates, alcohol as well, and element exposure from work, as the case the patient had exposure to cement. And so then Maria also pointed out the time course, because even though the patient had seizures and a really important etiology was hypoglycemia or hyponatremia, such as Smith pointed out, the fact that it was a subacute course kind of made us think that maybe not a metabolic cause in the first place in our differential, and so we should prioritize, also because of the fact that it was a young patient, infectious causes such as granulomatous etiologies and fungi, and inflammatory causes, as it was in this case, an autoimmune disease, and a neoplasms as well. And the other part of the neural differential equation that Aaron has taught us many times is the localization of the lesion. And I really like the fact that you guys kind of thought about intracranial versus extracranial causes of altered mental status, and how imaging was going to be key to think if this was intracranial or extracranial, and also signs of focalization in the physical exam. Another fact that you mentioned was who was this patient and the exposures that he had, such as his work, but also thinking about etiologies or infectious etiologies like herpes simplex or neurocysticercosis, that is a very, very common cause, for example, here in Peru, of seizures, and also travel history, social history, and comorbidities. Also, the other symptom that was important in the history was the fact that the patient had headaches. And so very early on, Zoya pointed out the red flag symptoms for headache. And so we have the SNOOP mnemonic in that we should think about systemic symptoms, such as this patient that had fever, post-ICTA fever. Also signs of neurologic focalization, onset, or like a new onset headache, or a change in characteristics if the patient had maybe a chronic headache type symptom, and also the onset if it was a thunderclap, a headache, and all the 3 Ps that are papilledema, pulsatile tinnitus, or if it was caused by a positional or change in position, and finally if it was precipitated by exercise. And I also mentioned a really important point that in older patients, we should think if it's a first onset seizure, we should prioritize a stroke versus in younger patients in which we should think about autoimmune causes and infectious causes on top of our differential. And then Smitha really pointed out a really good pearl, and it is that a BMP is a release exam that could be life-saving for the patient, because if we check for hyponatremia or hypoglycemia, we can really give the patient rapid treatment that could save his life. And I think maybe the highlight of the VMR for me was the differential for lymphocytic pleocytosis that Smitha mentioned, and she divided lymphocytic pleocytosis was a synonym for inflammatory etiologies, and she divided it in infectious causes and non-infectious causes, in which infectious causes, we should think about viral etiologies, granulomatous diseases, fungi, and parasites. And in non-infectious causes, we should think about autoimmune etiologies, like this case, and malignancy. And also, Soya pointed out that the normal glucose and protein in the LP made us less likely the possibility of this being a bacteria causing the seizures in the patient. And finally, a really important pearl that also Soya pointed out was the fact that the patient had a second LP that showed an improvement in the number of cells, but there was no clinical improvement. And so some really important learning is that the clinical improvement always comes first rather than labs. And well, finally, the diagnosis was autoimmune encephalitis, in which we should prioritize anti-NMD antibodies, because it is the most common, and there are a lot of antibodies that could cause autoimmune encephalitis, but other systemic causes that could be part of an autoimmune encephalitis are sarcoid, lupus, and Sjogren's disease. And so that's all, and thank you so much for the case. It was really great.
Thank you so much, Valeria. Those are incredible teaching points. Thank you all so much for coming today. I learned so much from you all. Smitha, as always, it's a pleasure.
Always.
And we look forward to seeing you all next month. We don't have a date yet, but if you're interested, or you know friends who are interested, feel free to message either of us or the CP Solvers on Twitter, and we'd be happy to have you discuss or present a case with us in coming months.
Thank you all so much.